Thanks for being here. I'm really excited about this panel. I'm a reporter for CNN, and I cover all companies that face the American consumer, as well as food companies. So obesity is definitely part of my beat, and I'm very excited to have an expert panel here who are on the front lines of fighting this epidemic every day. So we're going to talk about some solutions, what's working, what's not working, and in good Milken form, they represent a cross-section of government, academia, and the private sector. So I'm going to start on my right with Bill Dietz. He is the newly appointed chair, right, as of yesterday, of the Sumner Redstone Global Center for Prevention and Wellness, Milken Institute, School of Public Health, George Washington University. Next to him, Debra Eschmeyer. She's the executive director of Let's Move. I'm sure all of you know what that is. It's the First Lady's program dedicated to reducing obesity. Next to me, I have David Heber, who is the founder for the Center of Human Nutrition at UCLA. To my left, Jonathan Fielding, professor of health policy and management and pediatrics at UCLA. And Patrick Carroll at the end, who is the chief medical officer of healthcare clinics for Walgreens. I'm going to start very high level here, and I'm going to toss this to you, Bill. We have thrown, it seems like, a lot of different things at obesity to try and reduce the rates. Soda consumption has come down. There's evidence that caloric consumption has come down. People are more aware about exercise and movement, yet there doesn't seem to be a dent in the rates, especially for adults. What other tool is there? What other piece of information are we not paying attention to that we should be paying attention to?
Well, as you suggested, there's been a big focus on childhood obesity. And I think in doing so, we've forgotten about adults. Excuse me. If we look at the prevalence rates, children have been flat, 2 to 19-year-olds, for about a decade, whereas the most recent data suggests that adult obesity is continuing to increase. And there's some insight about the ages at which obesity develops. If I could have the third slide, please. Do we have the capacity for slides? Yes, there you go. So if you look at this figure, which are the latest data from the National Health and Nutrition Examination Survey, you can see that 9% of 2 to 5-year-olds have obesity. And I should mention we should be using people-first language to talk about people with obesity, not obese people, because that's an identity. But in any case, 2 to 5-year-olds, 9% have obesity. That doubles in the 6 to 11-year-old age group, and it doubles again in the 20 to 39-year-old age group. And the fact that children's curves are flat, that there's been no further increase, suggests that the kinds of policy initiatives like Let's Move is introduced in schools and the multiple changes that you described may not be enough to turn the corner on childhood obesity unless we deal with these 20 to 39-year-olds who themselves have an increase in the prevalence of obesity and who are parents. And I believe that if we begin to focus more intensively on this age group, we may have a twofer. We may be able to reduce childhood obesity at the same time that we're reducing the big increase in adult obesity.
Now, Jonathan or David, either one of you, can you weigh in here and talk to us about perhaps how you target this age group, the 20 to 39-year-olds, and getting them to really change their lives?
Well, you know, I think the key for us is when we looked at public health efforts in smoking, it's very relatively easier to get people to cut their smoking, although it's a very expensive proposition. And what we have in smoking is an addiction to a particular substance we can identify as nicotine. In terms of obesity, that age group, first of all, is relatively young, relatively disease-free, but they may be stressed about their economic situation. And often the answer to stress is either a soft drink or a chips, and certainly they may not have the time to really exercise adequately. So how do you change people's behavior? We have a lot of science on that. There's something called the Prochaska di Clementi, stages of change. You make a person aware of the problem. You educate them. You move them to action. And once they take action, you continue to reinforce that action over time so they maintain it. Some very sad data about exercise gyms came out in the Wall Street Journal last week, showing that for most gyms, by the end of 1 year, they only have 7% of participants still in the gym. It was a little better for CrossFit and cycling, but very, very discouraging results. So what I think we need is a person-to-person contact beyond our technology. And we have evidence now there are these mirror cells in the brain which are involved in autism. And we know that people, because of these mirror cells, when you look in someone else's eyes, and we scan both people's brains, as you tell a story and you engage someone, the two brains start to light up in the same places. So you can get a person to understand where you're coming from. And so I think the whole thing is getting, there aren't enough doctors or pharmacists or dietitians to do this. I think we need to get to the public. We need to get to the lower socioeconomic groups where this problem exists. And we need to go to a person-to-person change model where people are incentivized to change and then reinforced with ongoing care. So somebody calls you up and makes sure that you're staying with that behavior. And we don't have that now in public health. We have pronouncements, but we really need to reinvent our intervention for this particular problem.
Well, Debra, you're really on the front lines of trying to get this message to the public, right?
Yeah. Yeah, and so actually, and I do want to take a moment to pause and reflect a little bit more on the data, because I don't want to take for granted the incredible progress that we actually have seen with our youngest generation. In the 1970s, child obesity rates were at 5%. And we saw this increasing trend of, I think did it peak at 21%? Is that right? Bill has this
no,
like
it's 17.8.
locked in. Well, that's now, but I feel like we were at 2007.
No, it's just been plateaued since 2003, 4.
Okay.
Yeah.
So it's actually incredible that we've seen it begin to decline. I mean, imagine you're a runaway train. To stop it and change and reverse course and to slow it down and put it back on track took a monumental amount of effort. And that is something that truly has taken everything from local elected officials to parents to private sector commitments of reformulating products that we have to continue to do, or we're going to actually see the 6 to 11-year-old statistics go to where 20 to 39-year-olds are. So like we really need to like even double down on all the efforts that we've been doing to date on our work in schools and our work with playgrounds, what we've done with convenience stores, everything with making sure that there's bananas at the checkout, to making sure that kids are getting 60 minutes of physical activity in school. Those are the kind of things that we have to we really need to invest more in because we know it's working.
Go ahead, Jonathan, you wanted to weigh in.
Well, there are a couple things. First of all, we know that there's no single magic bullet here. We know that, for example, exercise is important, but a number of people have the false idea that you can kind of exercise your way out of a weight problem, and that just doesn't, when you do the math, it doesn't compute for most people unless you want to spend all your time exercising all day. The second thing, though, is that we have to understand that a lot of these problems are multi-generational problems, and there are probably some biochemical reasons for that. If you have one of the predictors of whether a child will have hypertension or be obese when they're an adult is what their mother ate as a child, the nutrition and the stress that she had during pregnancy. In Los Angeles, we looked at 5th, 7th, and 9th graders where we were measuring their BMI and as a measure of obesity, and we found that when we divided the county into 128 different places, and it's 10 million people, so it's pretty big, but if you looked at those that had the lowest income and had the lowest rate of jobs and had the highest rate of joblessness, and et cetera, you found that the rate was about 30% of those kids who were obese. When you looked at those who had higher incomes and the difference between, let's say, $30,000 and $100,000, they had a 5 or 6% level of obesity. So the socioeconomic factors are absolutely predominant here. And unless we start dealing with those issues of the social environment and the physical environment and the economic environment, we can't get to where we want to get to. So if you look at the 6 to 11-year-olds, I have a solution. I told you there was no magic bullet. Now I'm going to go back on that. So the 6 to 11-year-olds have been exposed to, they've taken the vending machines out of the schools, they're being more physically active, the foods being served are more wholesome ingredients. So maybe we need the 6 to 11-year-olds to do the menu planning and the purchasing for the family. They've learned, and before they unlearn the good things and give them more responsibility and then give them incentives for, in fact, getting healthsome meals on the table. Most of our kids don't do any food preparation these days, but maybe that's the way to, and that'll solve the whole problem. There won't be any other problems.
Well, I mean, what you're talking about is really changing fundamentally behaviors that have been ingrained in our society for a long time, and very macro themes that really go into this complicated equation here. Patrick, you deal with adults predominantly at Walgreens coming in for medication. Tell us how your company is taking a more 360 approach to obesity.
Sure. I'll give you some background first of all. Prior to coming to Walgreens 2 years ago, 27 years, I'm a primary care physician by training and practice. My first 4 years out of my residency, I actually worked on the Navajo Reservation in Shiprock, New Mexico. And then returned in 2009 to 2011 to do a school-based health center network development. So it was a really interesting experience, that 25-year gap where at the beginning we saw the diabetes and the obesity, and then when I came back again, all the complications from obesity, end-stage renal disease, cardiovascular disease, all of those complications had really come to fruition. So it's a real passion of mine. Last 2 years at working at Walgreens, it seems a little far way off from the Navajo Reservation, right? But what attracted me to the work there, it's a very consumer-centric organization. Every day we have 9 million people that come in and out of our stores. 2 million of those are actually connect with us digitally. So what we look at is how do you connect with this large population to drive healthy behaviors. So we actually came up with a patient affinity program called Balanced Rewards. We have 85 million people signed up with that. And what you get from Balanced Rewards is you get points for healthy behavior. If you walk, if you run, if you read health content sponsored by WebMD, you get points for that. You know, my Apple Watch is hitched up. I actually get points that translate into money shopping at Walgreens based on activity. 400,000 apps are actually attached to the Balanced Rewards program. So what we look at is how you actually touch a larger population, particularly the adult population, to drive healthy behavior. And it's based on some of the learnings of Dr. Fogg, who's a behavioral psychologist at Stanford. And what they realize is that small rewards frequently, constant reminders, really move the ball down the field as opposed to the once-a-year HRA that an employer may give. And then one final comment is, as a primary care physician, I might see a diabetic patient 2 to 3 times per year. The average diabetic who fills their scripts at Walgreens comes in 40 to 60 times per year. So we have many, many more touches than even the primary care physicians. Well, I remember I had 15 minutes to see that diabetic, to do 3 minutes of nutritional counseling, and I always felt that I was cheating them. So I think we have to look at bigger, broader, digital touchpoint solutions for this problem, because it is a big, big problem.
And next year, all Walgreens customers will earn points for attending this conference.
I'd like to like to build on what you said, because I think it's very critical, is the ongoing care. You know, Medicare announced with a great deal of fanfare their intensive program for type 2 diabetes, and it was just a very few visits. I think for this particular problem, you almost need daily contact. And that's why I think moving to a public intervention kind of model at the right socioeconomic level is very important. There is a book by Dr. Michael Marmot called The Health Gap. And what he talks about is we have all of our physiological lists of things like exercise, eat less fatty foods, et cetera. But there's another list. Do you have a job? Is your neighborhood safe? Do you have a place where you can exercise? Does your employer give you the time to exercise? Until we deal with the social determinants of health, obesity is going to be very much influenced by that. And Dr. Christakis at Harvard has documented this in the Framingham community, where he looked at obesity over a 32-year period, and he found that if you knew people who were obese, you were more likely to be obese. And if you knew people who were thin, you were more likely to be thin, just using BMI data. So this social interaction, connecting people together is very important. And one of the companies I consult with is Herbalife International, which has 100,000 what they call nutrition clubs in 93 countries around the world, where groups of 20 people get together, educational materials are present, and then they use meal replacements, which have been proven over the last 30 years to be effective. In the Look Ahead type 2 diabetes trial, the more meal replacements people took, the more weight they lost. It's not a magic bullet, and I agree totally with Jonathan. It has to be multidisciplinary. You have to have the exercise, psychological support, and the education all needs to be part of it. But we know there's not enough protein in the American diet, at least in the way it's distributed. So people eat a little bit of protein for breakfast, a little more for lunch, and a huge amount for dinner, much of which they cannot utilize. So by moving people to protein throughout the day, and you can use plant-based proteins like soy, which are cost-effective and don't have a big environmental footprint. And I think those kinds of things are solutions that are practical. So exercise, protein, psychological support, and then getting contact with people, which I think this is great, the number of contacts you have, and maybe that's something to build on and expand, because I think it's almost a daily social modeling for another person. You have to model the behavior yourself. I always joke that a doctor who's obese and smoking a cigar is not going to be able to give a patient much good advice about losing weight.
I'm glad you brought up protein, because Americans love their meat. And in fact, the government just put out new dietary recommendations. A lot of people were hoping that the government would urge Americans or guide them to have less of it. David, this is something that we talk about. You know, does that need to change, and how much of an impact does meat consumption have on obesity, and can we do a better job on that front?
There's a large study that was conducted in Boston with the Nurses' Health Study and Health Professional Study. Large numbers of people studied over time and with dietary measures that showed that increases in meat consumption were associated with increases in the prevalence of obesity. That connects directly to the dietary guidelines. It also connects directly to global warming, because agriculture is one of the biggest producers of greenhouse gases, and within agriculture, cattle are one of the biggest producers of those gases, particularly methane, which is a much more powerful greenhouse gas than carbon dioxide. So in these dietary guidelines, the original draft, there was a recommendation to reduce meat consumption. There was also a sustainability recommendation that the current reliance on a meat-based diet is unsustainable. And the politics kicked in, as you might imagine. The meat industry was outraged, and both secretaries were called to Congress, in which they said sustainability is is no longer part of the dietary guidelines. We anticipated that, but getting the sustainability idea introduced into this year's dietary guidelines begins to set up the next round of dietary guidelines, which are coming in 2020. And I think by then there's going to be a greater sensitivity to the impact of global warming on dietary intake on the planet, and I hope a greater investment in looking at sustainable practices around nutrition.
Well, you know, our red meat has also changed since we were kids. There used to be a thing called meat tenderizer, which was used as an enzyme to make the meat softer. Today, the cattle are raised to have a lot of fat inside the muscle to make it tastier and have more flavor. The extreme of this, of course, is Kobe beef in Japan, which is mostly fat with little tiny bits of red meat. So I think when we look at different types of lean meats and proteins, one can make some suggestions there. But I think the environmental impact of that is huge, as you mentioned. And that's why I think plant-based proteins is something we need to advance. And the dietary guidelines talked about healthy eating patterns, including a vegetarian eating pattern. I think the millennials, or many of them, are semi-vegetarian or vegetarian in their practices from a health standpoint. So I think that we're seeing some movement of American dietary habits. But a Nobel Prize winner in physics once came to my office and he said, David, I don't understand it. You know, in physics, if we have a constant in the universe and we think it's wrong, we just do another experiment till we disprove the fact. And in nutrition, you can show almost anything you want in a particular study, and there's a lot of economic impact on public health initiatives, evidenced by what Bill just talked about in the dietary guidelines. And so I think it's an iterative process. We've been working, the dietary guidelines folks have been working at this for a very, very long time. The dietary reference intakes, I believe, started in 1994, I believe. and we have physical activity guidelines that we've issued. But by the time it's gone through this meat grinder of politics and influence, what comes out is a message that in television terms has a very low Q factor. It doesn't really motivate people to act. People don't pay attention to this advice. It becomes too vanilla, if you will.
But so actually to that point and making it non-vanilla and talking about the center of the plate, you know, this administration has worked really hard on updating my pyramid to my plate and having half your plate be fruits and vegetables. But I'm not sure if many folks are aware, but only 2% of marketing actually goes to promoting fruits and vegetables. So we spent a lot of time during this administration trying to make sure that we're meeting people where they're at with this. And one way has been through the Partnership for Healthier America, which is a separate nonprofit that works with private sector communities to get commitments, which the First Lady is the honorary chair of. Sesame Street and the Produce Marketing Association have worked together so that Sesame Street characters can be free of charge on fruits and vegetables. Because it's been proven that if Elmote is on broccoli, kids will eat it. Believe it or not, it works. And similarly, so that's the younger age group, but also PHA recently launched this FNV campaign, and I'm saying FNV. It's so FNV, it stands for fruits and vegetables, but basically it's marketing fruits and vegetables to kids, how they're used to, basically high schoolers and college kids, the way they're used to seeing it. So this is Steph Curry. You guys, Steph Curry is marketing fruits and vegetables. And Jessica Alba, Cam Newton, and like, so 50 celebrities are out there on billboards and on Facebook and on Twitter, where all the kids are, on Snapchat, right? Like, that's what we need to be doing to actually take over the plate again, right? And so I think we actually have, if technology is our friend, there might be a little video to play around FNV. If not, that's just a teaser, and you all need to just look up fnv.com.
You know, in California, with support from the National Cancer Institute, back in about 1982, was the 5 a Day for Better Health program. And the National Cancer Institute took a leadership role in pushing for fruits and vegetables because they have so many beneficial effects on the diet. And there are 100,000 what I call phytonutrients found in colorful fruits and vegetables. And this did make its way into the dietary guidelines because the different colors contain different substances, many of which have antioxidant and other beneficial effects. So I think what you're doing, I really applaud that, and have worked with the Produce Manufacturers Association before. And I think these new
We never talk about this with FMV, just so you know.
No, this is new. No, but I have been a huge fan. And I think what we do wrong in the produce area, my friend Adam Dernowski has looked at the cost of food versus what he calls nutrient density. And it turns out that some of the best foods for you cost the most money. And some of the foods that are least costly are full of salt, fat, and sugar. So what makes that even worse is that we've done studies on addiction to sugar, and we found that 50% of the people in our obesity clinic actually had a food addiction to sugar using validated questionnaires. And there is a receptor in the brain for the same addiction as smoking and gambling, and that's why these addictions go together, and why it was mentioned earlier today there was smoking going on in the casino. I'm shocked. There's smoking in the casino. But people who are gambling addicts also tend to smoke. The healthy addiction is...
We need to reframe the cost discussion a little bit, because I think Americans have always viewed the cost of food as a big factor in the way they purchase and consume food.
Right.
And as part of my reporting, what we did was we created a graph where it showed the cost of food as a percentage of someone's income versus the healthcare costs. And it's almost an inverted trend. As people spend less on food as a percentage of their income, they spend more on medical costs as a percentage of the income. So maybe we need to reframe the discussion around, okay, you may be saving money on one end, but perhaps spending more on the other. Now, I'm glad that the subject of marketing has come up, because I wanted to bring up the American Journal of Preventive Medicine published a cost-benefit analysis on reducing obesity in children, and it looked at 4 levers you can pull: a sugar tax, ending the write-off on children's advertising, increasing moderate to vigorous physical activity in schools, fostering better habits like not sitting in front of the television in preschool settings. Now, the first 2 stood out as getting the most bang for the buck: the sugar tax and ending the write-off on children's marketing on television. How frustrating is it from a policy standpoint, that those changes still have not been made or implemented?
Well, incentives are important. And whether you're buying an electric vehicle where you get a huge incentive or whether you're talking about food. Well, for example, at UCLA in the hospital, there's cross-subsidization. So the salad bar is relatively cheap. Some of the other foods that are not quite, don't have the same nutritional value are more expensive. And so you keep pushing that, and people then start getting the idea and start eating the right foods. I think the sugar tax is an obvious thing that's way overdue. And they did it in Mexico. It worked in Mexico. In the first year, I think the consumption was down about 12%. But the other point is you don't want to have those around. We need to. This is the best drink. And so I think incentives are absolutely critical. We know that incentives work, so wherever those can be applied, they should be. And if we don't think that marketing for children is good, then we shouldn't allow that to be deducted. It's a very clear incentive and disincentive. There are the free speech issues, but I think that the tax code can in fact get around that. So yes, it's overdue for the legislation that could be helpful.
We could be
let's be clear, it's a sugar drink tax.
Yes.
Not fruit juice.
No.
Well, it's 10% juice is included in that. And I think what we're seeing is that this is going to happen across the country. Berkeley passed it. San Francisco is putting warning labels on. Philadelphia is announcing that it's going to propose a sugar drink tax to fund early care and education centers. So I think it's going to happen. But one of the interesting,
that's how DC
DC has a sales tax rather than an excise tax, that does fund the Healthy Schools Act. But one of the things that they've observed in Berkeley, and this may happen in Mexico, is that sales in Berkeley have gone down, but sales in the surrounding communities have increased.
Contraband.
So I think we're going to start shipping sugar drinks to Mexico. It's reverse contraband.
Well, maybe if we had the same kind of law, that's why you want to harmonize, as they say, the laws, so that there are incentives in both countries not to have the very heavily sugar-laden soft drinks.
Right.
Now, has anybody looked at how much sugar Americans are consuming? Because we know soft drink sales have gone down, but I'm not sure that sugar intake has gone down. And the reason that I bring that up is because when I look at like a Naked, just to pick one company out, but a Naked juice, that's marketed as healthy, right? That's 100% juice. You look at that label and you compare it to a Coke, and there's more sugar in the Naked fruit drink than there is a Coca-Cola. So are Americans simply not drinking soda? They're opting for the healthier juice. But I mean, should we be maybe reframing that argument as well, or that debate?
There's a context of eating food. So the social context of it's very important. If you're a bicycle rider and you're riding 8 miles on your bicycle, you have to have sugar drinks to provide the energy to do that. So athletes take in sugar. So actually exercise, if we get people addicted to exercise, that gives them the room to then consume sugar. The problem with sugar in these colas with kids is that they're sitting sedentary and they're getting 9 teaspoons of sugar in every cola. There's only 2 teaspoons of sugar circulating in your body at any time. The remainder of that sugar goes right to your liver, and 50% of obese people have fatty liver. A small percentage get this inflammation of the liver, and a small percentage of them get liver cancer or cirrhosis and die. So this morning we heard from Atul Butt about the pathway of disease. I can draw that for him right now on obesity, type 2 diabetes, kidney failure, and heart disease, just as a straight line, and then to all the liver transplants at $250,000 a pop. For many of those are for fatty liver, which is now the 3rd leading cause of liver transplant. Number 1 is alcoholism and viral disease, or I guess number 1 and 2. And then number 3 is fatty liver. So this is, again, a preventable economic impact if we can get rid of this obesity problem. But it means engaging this economic engine of actively addicting people to sugar and fat and salt versus addicting them to exercise, which I call the only healthy addiction.
But to your point, sugar, the main source of sugar in the diets of Americans are sugar drinks. And even with the decline in sugar drink consumption, there's still a high intake of sugar because it's ubiquitous in the food supply, and products that you would never guess have that added sugar. In the diets of children, I was surprised a year or two ago to learn that the second leading source of calories is pizza. And the first leading source of calories in the diets of children are grain desserts, so think cookies. But with one exception, in adolescence, the single leading source of calories is sugar drinks. Pizza's number 2 or 3 in that group.
I mean, the point of the profitability linking to that is very great, because one of the largest nutrition companies in the world, I won't name them, bought a particular protein bar that had 10 grams of protein in it. They then lowered the protein to 8 grams because it was too costly, and then they got rid of the company altogether. So people need to be learning how to get low-fat proteins into their diet, reducing refined grains, and increasing fruits and vegetables. It's not rocket science, and then exercising 45 minutes every day. I think if you do those things in combination, and we incentivize people to do that economically or otherwise, or give them economic opportunity in their communities, in the low socioeconomic communities, I think that's the solution to the obesity epidemic.
When I go to public schools that are trying to change eating behaviors in New York City, I still, even though there's more fresh vegetables, they're teaching the staff how to cook on site as opposed to just warming things up in the microwave. One of the biggest culprits that I see on children's plates is pizza. Yeah. Why are we allowing our children to eat that crap?
Well, you know,
and apparently we need to add a Congress member onto the panel to answer the question.
You know, Jonathan and I were involved in one of the first school health programs in a very bad neighborhood called Beverly Hills, Malibu. And we found this was the toughest place to make diet changes, and I applaud the First Lady's efforts. This is so impacted by, we held a day for the teachers. All the teachers went to the stress reduction workshop. We were competing with AIDS education programs, other things. The kids were actually, to Jonathan's point, were taking home information on their cholesterol to their parents, and we discovered several families that had heart disease based on the kids taking the information home. So in this book by Mark Marmot called The Health Gap, he considers one of the solutions education. And so I think that and we also found that we were most successful on health in the first primary grades. By the time we got to high school, the kids were going off campus, smoking, going to various kinds of fast food restaurants. So you have a window of opportunity with young kids to really get them started on the right path, and I think that's where we need to go to early childhood education.
Well, we also need to think about the strength of the lobbies. I mean, why is pizza ubiquitous at schools, and is that in fact the right answer? Just the same way as why don't we have a tax on sugar-sweetened beverages? I think, you know, this is not to call out any particular organization, company, but they need to come along with this. This needs to be a partnership, and they need to understand that they can change, because people are still going to eat.
Right.
Whether they're eating pizza or something else. So we need to change, and even in the pizza, you can change the recipe.
Right.
Exactly.
Yeah. And to that point, though, every ingredient has a lobbyist, but it's obviously really important that the meal that 30 million kids eat every single day is a meal that has been approved by pediatricians and nutritionists, which is what was done with the Healthy Hunger Free Kids Act of 2010. And the pizza now has been reformulated where it meets the whole grain requirements and sodium requirements and whatnot. But what's really exciting about all of this is that when I keep looking at that data and thinking about the generation of kids that have kind of become accustomed to this new norm, they have grown up with celebrity chefs. They have grown up with a White House kitchen garden. They've grown up with the First Lady out there harvesting fruits and vegetables. They themselves are excited to be in the kitchen. Truthfully, they're the ones bringing their parents into the kitchen with all these new ingredients. They're kind of bored with this old standbys. Like we launched this Healthier Lunchtime Challenge 5 years ago at the White House, and then the winners of the U.S. states and territories come to the first ever Kids Day dinner. I mean, to me, that's like one of the most beautiful things we can do at the White House is open it up for these kids, and they create these recipes, and it's so competitive. because the kids love cooking, and they're coming up with these like incredible recipes that all meet the MyPlate guidelines, and it's affordable. And when you think about all the changes that we're working on, right, and all the different policies and programs and promotions, like what gives me eternal hope is like these kids are doing this themselves. They've got all these resources now. They know how to use the internet better than any of us, and they have access to learn and take over the control of their own health, and they feel good, and that's contagious, and they're addicted to it. And it's exciting. Like I have so much hope. I know we keep talking about like some of the dire things.
That's why they should do the menu planning.
Well, no. So Jonathan, I was worried about that comment because I think if you ask a 6 or 11-year-old what they'd like for lunch or dinner, they're going to say pizza.
No, but if you tell them that their allowance will grow.
There you go.
Incentives.
To the extent that they, in fact, they can figure out very easily on a computer, much better than I can on their handheld, how many calories. You tell them what the parameters are for what has to be served. You let them decide on the menu.
Yeah, to that
It's a
point,
win-win.
To that point, the social network now is so powerful. Kids go to restaurants and they photograph what they're eating so they can share it with their friends. I had this great dinner. Here's what the dish looked like. And so we have a lot of tools in China, where I was recently. They use WhatsApp all over the place, and they use it for constant contact. So maybe that's one of the solutions to this contact. You still have to have person-to-person contact, but maybe that follow-up can be made through technology. So maybe technology could also be our friend. And I think ultimately the marketplace will respond as people change their behaviors. It'll have to or go away. So,
but unless we deal with the issue of huge income inequalities, problems with social networking, the context in which people are struggling to make ends meet, where you have such wealth differences and people are afraid, what happens if I get laid off? I'm not going to be able to pay for any, the basics. And rent's a very high percentage of what people have to spend at all. Unless we can deal with some of those issues. I mean, if you look at the group, at this assembled group in the audience, I would say that the rate of people with obesity is extremely low.
correct.
And that's reflective, in fact, of the data for the U.S. And in fact, the people at the upper end of the scale in terms of income and social connectedness and the like are much less likely to have obesity. So we can't just, there's a whole bunch of things we can do, some in the broader environment, some in the specific environment, and behavior is a product of all those.
And Patrick, we talked about food deserts as a major problem, and how fruits and vegetables are not only expensive, to your point, but they're also unavailable in lower income neighborhoods. People have looked at whether or not that's actually a solution, but in your opinion, you think maybe not?
So I think what we're all driving to, this is a public health measure and a public health initiative. And the interesting thing when you work on a Navajo reservation is it is captive population. They receive all the health care at certain hospitals. You have public health clinics. You have community health workers. And so as a organization, the Indian Health Service did a lot of great work. They actually trained community health workers to actually show folks how to cook traditional grains and foods out at the chapter houses, which are these little community centers. We would identify through the school-based health clinic the kids who were really overweight and obese, and we had a camp every year, 300 kids up in the beautiful mountains of Colorado, and for 1 week we had nutritionists, and really focus has to be on activity. If you actually ask these kids, they're watching 4 to 6 hours of TV every year, every day, and every year. I wish it was every year. And so you got to get them moving. In terms of the food desert, it is a big issue. So if you go into a community like that on a Navajo reservation, where do they get their food? They get it at trading posts. It's a gas station, it's lard, it's flour, it's Spam. And there's a ton of candy and Gatorade right out front. So they don't have access to good food. So as a public health community, we kind of worked on how we're going to get better food out to the more remote areas on the Navajo reservation. So it really is a community approach to a major, major health problem.
But it's not just making fruits and vegetables available to a community. It's teaching them what to do with it, right? Because you can give them, kale, but if you haven't cooked that for years, then it's not going to taste very good.
Right.
Yeah.
I think Jonathan's studies in Los Angeles County were very easily able to geographically locate where the problem was within Los Angeles County, in East Los Angeles and South Los Angeles. And I'm sure that every city around the United States, we could find within the counties where are the neighborhoods that we actually go neighborhood by neighborhood with some of these innovative ideas and have some tests of what works, because I think we have to go where the problem is. You're absolutely right. Talking about obesity at the country club isn't going to do anybody any good. You've got to go to where the problem is. And we have to also define obesity correctly. And it's a much more prevalent problem than the BMI I think of as a canary in the coal mine. It's very useful for population surveys, for geographically looking at where this is. But I think we'll find when we go in those communities, there are a lot more overfat and overweight people than obese people in all those communities. The estimates in China today, there are 120 million type 2 diabetics. It's estimated, and it's an unbelievable number, that there are 500 million pre-diabetics in China. They have the same incidence of type 2 diabetes, which I call diabesity, that we have here in the United States, because it's totally linked to obesity, and it deals with the number of years that your pancreas is exposed to high blood sugar levels. So that's why we're seeing it in teenagers. All you have to do is stress out your pancreas for 10 years. It doesn't matter what age you start at. It used to be people started at 40 or 50. Today, they might be starting at 10 or 11, and by the time they're 25, they've got type 2 diabetes, which we used to call adult onset diabetes.
We have this notion of, which has gotten a lot of currency, of health literacy, trying to understand the things that you need to get the care you need and to get reasonable quality and to get good access. We need this concept, and maybe it exists, and I'm just not aware of it, of food literacy, where you want people that understand enough to be able to compose a diet, to make wise choices. And I'm not sure if those online courses exist, but those certainly would be nice. The other thing, though, is in terms of physical activity, and I'm not trying to downplay its importance, because with screens, we know that there are more sources of things to do on screens. Now, in fact, a lot of people here are on screens right now. There have been several studies that have shown that the time on screens is inversely proportional to the physical activity. So if you want kids that are to be physically active, you have to limit screen time. Right. Now, the other thing you could do, and I don't know why this has not grown, there was these machines where you had to be working out in order to have your television on. They've powered your screen. And I don't know whatever happened to that, but that seemed to me a very good idea.
that was proposed by a 9-year-old in a letter to the New York Times about 20 years ago. Yeah. And I want to challenge a couple of statements. I think it's very, I think it's very important to recognize that physical activity has a very important role to play in prevention.
Correct.
But once you've developed obesity,
right.
It will change body composition, but you will not lose weight.
Right.
So that's number one. The other thing is that, we published the first study showing an association of television viewing and obesity in children. And we thought at that time we had some measures of physical activity. And when the television viewing is not related to physical activity, and suggesting that the effects of television on obesity are mediated through the advertising directed at children and the consumption of those foods.
Yeah, I would like to push back a little bit on the studies that have been done in the past on physical activity, because I think for many years we talked about people just walking as the primary form of exercise, 10,000 steps a day. And I think what we're seeing today, especially in the sedentary population, is that the muscles actually eat themselves up. As I'm sitting here, let's say I was sitting here for 8 hours a day, my hamstring muscles would get shorter because they think I know what I'm doing, and so they're going to try to fit the shape of the chair. And so if I'm sitting here doing nothing, my muscles are going to eat themselves up. We know that what you need to do to build that muscle up is to eat more protein and to exercise and have that protein 30 minutes to an hour after doing resistance exercise, which is something we never talked about 20 years ago. And what that's important for, so your number of calories you burn per day is related to how much muscle is in your body and how much lean mass is in your body. It's what we call the resting energy expenditure. So if a woman has 100 pounds of lean, she burns 1,400 calories a day at rest. Her husband with 150 pounds of lean burns 2,100 calories at rest. The higher your calorie burn, the easier it is to maintain your weight. So if you gain 10 pounds of lean, you've gained 140 calories of resting energy expenditure. So for many people, combining diet and exercise is critical. They work together, and to make that work, you need to have the psychology and behavior change and getting on a healthy addiction. So I think, as we start to identify the physiology of this, I think we're going to be really in good shape. A recent study was very interesting. We used to say that lifting weights didn't burn any calories, and it's because we measured the calorie burn while they were lifting weights. It turns out most of the calorie burn is after you stop, as your muscles start to conduct protein synthesis, and the actual total calorie burn is very similar for aerobic and resistance. And resistance is very important for women, for bone health, for muscle, for weight maintenance, especially as women age and go through the menopause. So I think we want to do real prevention. We have to really not just do what people are willing to do, but really teach them the proper way to stretch and the proper way to exercise.
I'm in favor of any research that de-emphasizes cardio. Just putting it out there.
Yeah. Well, they're now recommending you do your cardio at the end of your resistance exercise, or interval. The other one is high-intensity interval training, where you just aim to keep your heart rate up to 100 and whatever it is, your particular, let's say it's 130 for the entire period. And I do things like clamshells with a rubber band on, and I'll tell you, my heart beats hard when I'm doing those exercises.
I do clamshells too. We have definitely something in common. The other thing we haven't talked about, so we've talked a lot about diet, we've talked a lot about exercise. One thing we have not talked about is the stigma of obesity, that there is a perception that these are people who have a weakness, that they can't control themselves. How much of an obstacle is that to getting at decreasing rates?
I think this goes to your people first
Yeah,
language.
well, it's huge.
Huge.
I think that when we talk about obese people, that gives them an identity. They have no identity independent of their weight. But when we talk about people with obesity, we're talking about people with a disease or a disorder who may also be women, they may also be parents, they may also be employees. And the stigmatizing effects of obesity are much greater around obesity than any other disease. We talk about people with diabetes, people with autism, people with asthma, but we talk about obese people. And I think that if we're going to transform the bias that exists, we have to start with that language. We have to change the language. But we also know that the stigmatizing effects of obesity actually contribute to obesity, that instead of incenting people to lose weight, it's just the opposite, that they're more resistant to weight loss, they're more likely to overeat in response.
But isn't it also true that people's social circle, their neighborhood, and what they perceive, if everybody in that neighborhood is obese, they may be less feeling that they need to do something about it.
Well, the Christakis data that I think David mentioned earlier, the spread of obesity across networks, was much more powerful if you had a friend who had obesity.
Yeah.
And interestingly enough, spouses and siblings were less affected, and there was no neighborhood effect whatever.
I think there's a deeper issue here beyond obesity itself, which I used to have a lecture I gave called "Fat is a Feminist Issue," and it really turns out we hold women to a different standard than men. Many men think this is a muscle, and so whereas with my daughter was great. She's always, am I fat? Am I fat? It's almost a stigma to the point of being a cultural phenomena in our society. We need to start appreciating people's body shapes, regardless of what they are. I'm a huge fan of Meghan Trainor's song, "It's All About the Bass," because I think that we need to start telling women it's okay to have a different body shape than the models on the runway. One of the most effective pieces I did when I was on a news program once was to have a beauty queen who walked down the runway and then a girl who had an eating disorder, and there's similar body shapes. So we are creating eating disorders in many, many women as a result of this kind of stigma against obesity. So it's not just the very obese that are the problem with stigma. It's almost many, I don't know what the percentage is, but a huge percentage of women. We talk about the freshman 40. We talk about all this. This is a problem for almost every woman as she's growing up.
Are there any efforts to change that? Is there any concerted efforts to do anything about that perception problem?
I mean, look at what Barbie just did. I mean, you've got a whole reformulation of the next generation of what everyone in this room grew up with one version of a Barbie.
I didn't have a Barbie.
Except for Bill. G.I. Joe. Ken, there you go. But I do think that it's what I think has been really empowering and authentic to thinking about the First Lady is like showing her fitness routine. I don't know if you guys have seen her workout that she released last year, but it's incredible. You have to have muscle to do this workout, right? Mm-hmm. And like it's about how you feel and about the reason that you do physical activity is because physical activity helps with an active brain. Like there's just all the science behind that, of course, but it's not about this ideal image. You know, we've never put that out there. It's really about, again, feeling good and whatnot. But I have to say, just listening to the panel, who I have respected for so long, and it's so fun and delightful to be sitting here amongst all of you. But I really want people to understand, especially for the aspect of like access to healthy food and how much effort that this administration has taken on that effort, and how schools really truly are that phenomenal institution where we are reaching all of the kids, no matter what zip code, income level, where they now have the access to healthier food, and they're getting this education, which is so essential. And the same side of 1 in 3 being overweight or obese for our children, we have 1 in 5 that are hungry, and a lot of these are the same kids. And this is 46 million Americans right now on the Supplemental Nutrition Assistance Program, 15 million of them kids. Half of the recipients on SNAP are kids. And we're working really hard to come up with creative solutions for many decades here of thinking through technology to really address some of these access issues for the healthiest food products and making it more affordable. And a lot of this, again, has been all the tools that we've been saying and using at our disposal, from policy to programs. But I want folks to be thinking about, again, like thinking about the institutions and the practices that we've done so far to date with schools and with the existing policies, that we're really taking and using the best tools at our disposal to be meeting these problems. And it's hitting both sides of the coins of hunger and obesity.
There's one thing that's very clear, and that is it's easier to prevent obesity than to try and treat it.
Correct.
So from a public health standpoint, that's where we really need to make sure we're devoting our time and energy, not exclusively, but at least as a very, very high priority. Because if we don't do that, we're on the back end of the curve, where it's going to make it much harder for us to deal with this issue. And the burden on people's lives and health is just huge. So prevention is absolutely critical. And I think when we look at this chart that Phil started us out with, that's where we have to look. And it's interesting that in LA we saw a reduction in the 2 and 3 and 4-year-olds that were in the WIC program, because the WIC program had nutritional counseling, plus it had gave out foods that were nutritious, and it gave good counseling. So if you do those things and you start early, you start at the time of birth or even before, and let's not forget breastfeeding, which is also very important for a whole bunch of reasons, we have a much better chance of getting to where we want to get to.
That's a subject for an entirely different panel. But thank you so much to all of you for not only sharing your insights, but fighting this epidemic in the country. Really appreciate it.